great pleasure to start off the academic year rheumatology grand rounds today with Dr. Felson. Dr. Felson, as you can see, is professor of medicine and epidemiology at BU. And since for about the last 13 to 15 years, he's been professor of medicine and public health in the arthritis epidemiology unit in Manchester. So he went to Harvard undergraduate, where he majored in history and biochemistry, and then went to Johns Hopkins for his for medical school, and then did his training in internal medicine at Case Western, then went to BU, where he did his fellowship and also obtained his master's in public health. And to say David has been productive and a world leader is a vast understatement. He has received almost every major award you can think of: the Howell Prize, Lee Howley Prize from the Arthritis Foundation, the Henry Kunkel Young Investigator Award, the Ziff Prize. He has lectured to us before as the Chuck Christian lecturer, and he's published almost 700 papers with a huge citation number, because these papers, which are largely focused on osteoarthritis and its causes and treatments, but to some extent RA clinical trials as well, these papers have been many of them have been seminal and have been cited and used for not only for practice, but leading for additional research. So it's a great pleasure to have David join us today. So Dave, we look forward to hearing about osteoarthritis.
Thanks, Lou, and thanks for inviting me. It's always a pleasure to get to see my new friends and old friends at HSS. There's a lot going on in osteoarthritis, and I want to sort of give you a taste of that a little bit today. Some of it relates to an increasing focus, not so much on structural abnormalities in osteoarthritis, cartilage loss, for example, but rather on pain and how we treat pain and how we try to couple the treatment of pain with the treatment of the structural disease. So I have no disclosures. Pain is the primary clinical symptom we get faced with as clinicians taking care of patients. It causes the functional limitations and reduced quality of life and medical care seeking that we all see in patients. Knee pain in the community is incredibly common. It's about 25% of adults, actually, in multiple surveys, report experiencing knee pain on most of the preceding 30 days. And of those age 40 and by MRI and X-ray, most have evidence of osteoarthritis. Joint replacements, the huge majority are for osteoarthritis. This is 790,000 knee replacements. Now, I didn't update this. This is 2010, but the important number is that by 2030, not far away, there's expected 3.5 million in the United States yearly, and we are on track to reach that number. So the number is now over 1 million a year. There's also an increase in hip replacements that isn't quite as dramatic as the exponential increase in knee replacements. Knee replacement rates are also rising a lot in other countries. That's in part due to the aging of our population and to increasing rates of obesity. So we don't have any treatments that alter structural progression in osteoarthritis, unlike in rheumatoid arthritis. And we focus obviously on symptomatic control with nonsteroidals, acetaminophen, opioids. These all have fairly small treatment effects. And with respect to nonsteroidals, I think we all are concerned about the relatively poor safety profiles in many of our older patients. Healthcare providers and patients don't optimally use exercise or weight loss strategies. They're not so easy to comply and adhere with. And other non-pharmacological approaches are either not widely used or have not been shown to be effective. So, for example, braces are actually reasonably effective, but the adherence is poor. So when we start thinking about osteoarthritis-related pain and targeting pain therapeutically, it gets pretty complicated very quickly. We recognize that there are a variety of psychological and sociocultural factors that contribute to pain. There's pathology in the joint, especially synovitis. There's probably neurobiological mechanisms. And then, as we all know, particular activities induce pain, probably from the activity causing biomechanical stress in areas of a joint, in local areas of a joint that may not be protected well from that stress. So I'm not going to get into psychological and sociocultural factors, which overwhelm me. I can't figure out how to grapple with them, even though I know they're terribly important. What I'm going to do is talk about the structural features that generate pain and osteoarthritis, the nociceptively innervated tissues in the joint, and their involvement with the nervous system, both peripherally and centrally. I'll talk about neurobiological mechanisms, which is a focus of my colleague, Tuhina Nyoji at BU. And then at Lou's request and Kathy McLean's request, I'm going to talk about the Apos therapy as an example of altering injurious load. And I'll do that toward the end.